First, I'd like to welcome everyone back to EMS Monthly Education hosted by Sanford Health. I hope everyone is doing well, enjoying this beautiful weather that we're having. Um, this month, we will focus on special needs, which will be good for 2 hours. The objectives that we're going to cover here, we're going to talk about different special needs patients. We've got two different case studies. We're going to talk about the role of the caregiver and the overall assessment when it comes to these patients, these special needs patients. Now, when we talk about special needs patients, we're talking about patients that are patients with mental, patients with emotional, or some type of physical disability. This person may need help communicating, they may need help moving, overall, may just need help taking care of themselves. When it comes down to the different causes of these special needs patients, we have patients with what we call congenital diseases, and or they may just have some type of abnormality. They could have been born with a heart abnormality. They may have Down syndrome, or they could have had some type of birth defect. One of the big ones that you're hearing more and more about are your patients that suffering from developmental delays, such as those that are on that autistic spectrum. Now, when it comes down to these patients and your overall assessment, this can be very challenging. Not only are you dealing with these patients with these special needs or these abnormalities or these congenital diseases, they often have other medical problems like your different heart conditions, hypertension, asthma, diabetes, and so forth as well. And then on top of that, we're dealing with your different specialty equipment that goes along with these special needs patients. And so, once again, they can be very, very challenging. So, your dispatch information for tonight, you're going to be dispatched to a residence for a sick person, a sick person. You're going to be dispatched to a residence. You've got a 19-year-old male with a fever, 19-year-old male with a fever. You arrive on scene. This is your general impression. You got a patient that's lying in a semi-Fowler's position in bed. He looks at you when you approach, but doesn't say anything. His mom is there. She tells you that he's been running a fever since earlier in the day. She also states that home health nurse was on scene earlier. She contacted the physician, and the physician requested the patient be transferred or transported for further evaluation. So, your general impression. You move into your primary assessment. Once again, 19-year-old lying in a semi-Fowler's position in bed. He's being suctioned by his mother. His eyes are open and he recognizes your presence. Airway patent. He currently has a tracheostomy tube in place and he's being suctioned. A ventilator is in place and it's breathing or ventilating the patient at 14 breaths per minute. You assess breath sounds. You notice rhonchi in his bilateral upper lobes. You assess circulation. You've got a radial pulse that's rapid, strong, and regular. His skin is pink, hot, moist, and there's no external bleeding. Once again, our overall goal of the primary assessment is to identify life threats and manage those life threats as we go. How would you categorize this patient? Let's see, Marshall County said sick. How would you, Kadoka said sick. McIntosh says sick. Okay. All right. So what makes this patient sick? Marshall County said fever, raspy breathing. Okay, all right. So we've got some abnormal breath sounds. His skin is hot and moist. Burke said that hot, moist skin, the rapid pulse, the breathing. Okay, all right. Any emergent treatment? Kadoka said the rhonchi, fever, hot, moist skin. Would you provide any emergent treatment for this patient right now? Kadoka said keep suctioning. Okay, all right. Any emergent treatment. After the suctioning, he appears that his airway is patent. McIntosh says temperature. Okay, keep that thought, McIntosh. So, with mom there, how important is her role or the caregiver period? Kadoka said very. Marshall said very. Okay. Marshall said very. Kadoka said very. Dawn said extremely. McIntosh, very important. Marshall, helping info. Burke said she knows the history. Yes, indeed. Yes, indeed. She knows the history and the equipment. So, yes, that caregiver, that parent is going to be very valuable. They're going to have very valuable information. And so, we've talked about this before. As providers, we have to listen to them because they care for that patient. They know that patient's history. They know the medical needs, the medications, the dosages, and then on top of that, they're basically experts when it comes to the equipment that that patient has. All right, so we talked about he has a tracheostomy. Now, the pictures, I put a lot of pictures in there because some have had the opportunity to see tracheostomies before, but then we have those that have not had the opportunity. And so I just want to give them an idea of what's going on. But this tracheostomy tube, this is the actual tube that you're looking at. This is a curved tube that basically seats on the in an opening in the neck. You've got three different parts. You've got an inner cannula, and then you've got an outer cannula, and then a lot of them will have a guide, what's called an arbitrator. But you've got this adapter here, which is a 35 millimeter adapter, and guess what? It fits every one of your bag valve masks in your first in bag, infant, child, and adult. So that 35 millimeter adapter fits all of your bag valve masks as well. Some of your complications that you're going to deal with when you come in contact with these tracheostomy tubes, there could be bleeding at the site. It can be dislodged accidentally or intentionally, but one of the big ones are going to be your plugs, your mucus plugs. Now, that tracheostomy tube, once again, seats right into the neck, into the trachea. This is a surgical opening in the front of the neck. And when these patients are on them, a lot of times it may be used for a long-term ventilator. For that long-term ventilator use, that patient's able to pass air in and out of that tracheostomy tube. Now, if that person is on a ventilator, they will not be able to talk to you, so you may have to find alternate ways to communicate with the patient. But if that patient is not on the ventilator, a lot of times they'll be able to speak to you by covering that stoma opening. And so finding those alternate ways to communicate, is going to be very important, is going to be helpful as well. Ventilators, we mentioned that he was on a ventilator that was breathing for him at least 14 breaths per minute. Now, when it comes to these ventilators, guess what? They can be very intimidating. One of the things that we do not want to do as providers is go in and start tampering and changing settings when it comes to these ventilators. Doesn't matter if it's a home ventilator or if it's a portable ventilator. Once again, this is where that caregiver, this is where that parent comes into play, and their expertise. They can tell you all about this ventilator, but one of the first things that we want to do as providers is just make sure it's working properly. Listen, once again, listen, not just actively listen, but listen with empathy when it comes to that caregiver, because they're going to be an expert when it comes to these devices here. Simply going in, changing settings, you can injure that patient, um, basically injure that patient. Now, you've got your home ventilators, and then you've got some that are large and bulky, and then you've got some that are a little bit more compact. And then you've got your portable ventilators, where these patients are able to travel, and they work the same as your home ventilators. The biggest thing that you have to worry about when it comes to these ventilators are the different alarms that go off. You have like a low pressure alarm that happens, a low power alarm, and then a high pressure alarm. And you're going to have on that digital display, you will actually hear the alarm, and it'll identify whether it's low pressure, low power, or if it's high pressure. When it comes to those low pressure alarms, 9 times out of 10, you're going to be dealing with a leak somewhere, or something has lost connection. So reconnecting or making sure that you have a good seal, especially when it comes to that tracheostomy tube, is going to be very important. Your low power alarm, this is going to be battery issues. So simply plugging it into a power source will clear this alarm. And then if you hear the high pressure or see the high pressure come across the display, you're going to be dealing with an obstruction or that mucus plug that we talked about earlier. Now, you move into your vital signs, obtain your baseline vital signs. You got a heart rate of 111. He's going to be satin at 98%. The vent is breathing for him at 14 breaths per minute. You got an end tidal of 41 with a blood pressure of 118 over 62, and that MAP, mean arterial pressure, of 80. Any concerns when it comes to the vital signs? Marshall said the pulse is a little fast. McIntosh says the same thing. Burke, Kadoka said the same thing, and Dawn. So we're dealing with someone with tachycardia. Now, normally, resting heart rate should be 60 to 100 for an adult. We're dealing, and I think he was 19. He would be considered a pediatric. But actually, no, he would be considered adult at 19 years of age. But 60 to 100. He's got a history to where he's bedridden. His heart rate should be in a range of 60 to 80 to 60 to 80. So the tachycardia is going to be somewhat of a concern here, somewhat of a concern. You obtain a temperature on the patient, and you got a temperature of 101.2. So this could be the reason that he is tachycardic. You move further and you interview the caregiver or his mom. She states that he's had a fever, no allergies. His meds are Tylenol, Ensure, Baclofen, Gabapentin, and Paxil. He's got a history of quadriplegia. This is going to be due to a spinal injury. He's ventilator dependent, and he's got a history of depression as well. His last oral intake, Tylenol, she's been given to him every 4 hours, and he had his Ensure 2 hours ago. The home health nurse came in for a visit, contacted the physician, and the physician requested the patient be transported. So easy transport, very easy transport. Moving deeper into our interview process, this was a gradual onset and it started about 5 hours ago. Any concerns with the interview process? Okay, Marshall said no real concerns, no concerns. Okay, pretty much clear cut there. Pretty much clear cut. Okay. So no real concerns. All right, being that this patient is unable to speak to us, unable to talk to us, we basically, let's see, McIntosh says Tylenol, but still has a fever. Okay, all right. We complete a head to toe assessment. Scalp's unremarkable, face unremarkable, no jugular vein distension. Trachea is midline. Chest, you've got rhonchi in that right upper lobe and it's diminished in the right lower lobe. Abdomen is soft, none tender. He has a colostomy bag and a G tube. A colostomy bag and a G tube. When we talk about a colostomy, this is what a colostomy is. This is where either the large or the small intestine, a portion of it, is attached to the abdominal wall. And this is going to be the actual bag, the external bag, the colostomy bag. The complications here, hygiene has to be on point because infection, they're at a higher risk of infection and also irritation to this area. So you've got your colostomy itself and the colostomy bag. And then we talked about a G tube. This is the actual G tube on the end. You've got a distal cuff that air is about 10 cc's of air is entered into that distal cuff. And this is what keeps it in place here. This is basically a feeding tube. The gastrostomy tube is a feeding tube. It's also surgically implanted as well, and it passes through the abdominal wall into the stomach. You can also have what's called J tubes as well. Your complications here, you can have bleeding, you can have irritation around the site, it could leak from cracks, and it can become accidentally dislodged or purposely dislodged or obstructed as well. All right, so you move deeper into your assessment. You've got a Foley cath in place. That Foley cath is full about 500 milliliters of dark cloudy urine. Lower extremities, upper extremities, both are unremarkable. You've got your Foley cath. With the Foley cath, once again, this is very important because we see a lot of this specialized equipment when it comes to Foley caths, and they're basically used to drain urine from the bladder. We always want to pay attention to the amount of urine, also the color of the urine as well. Also look for blood in the actual tubing. Pay attention to the tubing for growths that may develop in the tubing. Also pay attention to the smell. With some patients that develop these UTIs, and if they're bad enough, you can smell it actually before you get into the room or where that patient is. Your different complications with it is going to be infections, also trauma. You have some patients that accidentally pull the Foley cath out, and then you have some that purposely, I've picked up patients that purposely pull those Foley caths out. And as you can see here, you've got a balloon on that distal tube, but they purposely pull those Foley caths out as well. All right, so we log roll our patient. Upper back is unremarkable, lower back is unremarkable. There's no edema. When we're dealing with these patients that are totally bedridden, always pay attention to their lower back as well, especially for those that may have a history of heart failure. Typically, there may be pitting edema or swelling in their lower back as well. The fluid is going to move to the most dependent area. You assess their buttocks. You notice that there are pressure sores or pressure ulcer on that right buttock. Lower extremities are unremarkable. We've got a photo here of a pressure sore or a decubitus ulcer. The pressure sore, it may be called the bed sore. And here you've basically got injury to that patient's skin from being in that one position for so long. I always pay attention to their heels, their ankles, their hips, and also their tailbones as well. Once again, those at risk are patients that are bedridden, that aren't able to change positions. Okay. So, what are your concerns when it comes to this assessment? What concerns do you have? We've got a number of different specialty equipment that we're dealing with when it comes to this patient. Okay. Let's see. All right, keep that thought, Macintosh. Keep that thought. All right. Dawn said urine pressure sores. Marshall said cloudy urine, lung issues. Marshall said pressure sores. Burke said urine, pressure sores, lung sounds. Tony said urine, dark, dehydrated. Pressure sores also. Awesome, awesome. All of the above. All of the above. We've definitely got some issues when it comes to that overall assessment of that patient. Definitely has some issues when it comes to the overall assessment of the patient. All of this specialty equipment, we found a number of different concerns here, a number of different concerns. All right, so you prepare your patient for transport. You notice that his home ventilator is one of the older ventilators that's a lot larger and bulkier. You do not have a portable ventilator on your truck, nor does the patient have a portable ventilator. How would you transport this patient? Okay, Macintosh, Tony, okay, Marshall, how would you transport this patient? All right, so everyone that I called out, Macintosh said BVM. Tony said the same thing. Marshall said BVM. Kadoka said BVM. Yeah, yeah. Once again, guess what? That tracheostomy tube, that's a 35 millimeter adapter, and it fits your bag valve mask. It fits your bag valve mask, and it does not pediatric. Guess what? Fits right on it. Fits right on it. The adult BVM, guess what? Fits right on it. And you're able to ventilate. You're able to ventilate. So it doesn't matter which one that you're using, it's going to fit. It has that 35 millimeter adapter. All right. Now, you've identified concerns when it comes to the assessment. What are some other problems that you can run in or come in contact with this particular patient? What are some other problems that are things that can come up, but what could you do as a provider to prevent these things from happening? Okay, McIntosh says communication with the patient. Okay, that could definitely be an issue there. So we've got to find alternate ways of communicating. Marshall said placing the patient in a position of comfort. Okay. Okay, Marshall, keep that thought. Burke said, keep your patient calm. Okay. So, some of our special equipment, we've got the ventilator. We've DC'd from the ventilator, and you're bagging this patient. We identified that he has pressure sores and he's got that Foley calf. So he's got that tracheostomy. You're bagging your patient. He's got that Foley calf and he got pressure sores. McIntosh says patient handling. Yes. What are some of our concerns, or what could we do to prevent worsening of any of this special equipment? McIntosh says patient handling. Okay. And we commonly do it. I'm guilty, or I was guilty of doing it until I was told about it. I was actually an EMT, and one of my mentors told me about. Okay, Kadoka said pillows, offload heels. Yeah, yeah, yeah. When it comes to those pressure sores, making sure. I mean, something as simple as making sure that the sheet doesn't have wrinkles in it to worsen that pressure sore. That's going to be very important when it comes to like that, having that Foley catheter. A lot of times what we'll see is that patient's lying on that stretcher, and we'll place that Foley cath right there between their legs. Guess what? That old urine that's in that tube, all it's doing is going back. It's back flowing. It's back flowing. So one of the things that we want to do with that Foley cath is keep it at the level of the bladder to actually keep that urine from moving back in the bladder. And this can help to minimize the risk of further infection here. We talked about the pressure sores, the flat sheet, making, just something as simple as making sure that the lumps, making sure that the wrinkles, and just like Kadoka said, making sure that that heel isn't on the bar of, the bare bar of the stretcher, making sure you've got a pillow or a blanket or something. This is basically preventive measures that you're taking. These are preventive measures that you're taking. Now, when it comes to your field impression of this patient, that this is a basically simple call. You arrive on scene, he's been running the fever, the doctor requested transport. What is that physician trying to prevent at this point? What is your field impression? But overall, what is that physician trying to prevent? Okay, Burke, I see you. Kadoka, all right. Yes. 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 Listen to what I'm saying. Listen. Let's see. Adam said the same thing. Sepsis. McIntosh says prevent sepsis. Kadoka said sepsis. Burke, sepsis. Yes. This is preventive measures, preventable measures that's being taken place, and you're a part of it as a provider. Once you identify all of these problems, guess what? It's a simple call, but you can do more by helping or providing these preventable measures. And a lot of times I've seen providers go in and for something as simple as this, get irritated because they have to run this call, this simple call. But you have a lot of providers, listen to what I'm saying, that don't even think as far as that. It's a transfer. That's what we're going to do. We're going to move this patient over to the stretcher and we're going to transfer that patient. Once again, critical thinking comes into play. Infection. Infection is huge. Temperature for at least, especially if it's like 24, 48 hours, if they're running a fever, we want to think infection. If they're running that fever and you suspect infection, there's a possibility that person can be septic. You do not realize at the number of people in hospital, pre-hospital, that misses the whole concept of this. That misses the whole concept of this. My mother recently died a couple of weeks ago. She was in Texas, and if we did not move her from Texas, she would have died sooner. And it was all because of this infection. But she was so bad until once we brought her back, she improved, and it was it was too late. It was too late. So something as it may seem simple, but it's so important. Once again, you got your big four. You've got acute MIs. You've got strokes. You've got uh, uh, traumas, level traumas, and the fourth one is sepsis. It's sepsis. Uh Okay, Macintosh, keep that thought. We're going to talk about that in a few minutes. Macintosh says, how do you suction a trach tube? What suction tube do we use? We're going to talk about that in just a few minutes, Macintosh. All right. Um, so you detach the ventilator circuit from the tracheostomy. You start ventilating that patient at 12 breaths per minute. You carefully move your patient to the stretcher, secure him, load him into the ambulance. Now, should you let mom or should you let the caregiver ride? McIntosh says yes. Marshall said yes, comfort the patient. Kadoka said definitely. Yeah, yeah, yeah. Let that parent, once again, they're going to be a great source of information. A great source of information. They can tell you if there's any changes when it comes to their overall status. They can bring additional equipment that the patient may need. And then when you're thinking about, or if you have like a pediatric patient, Marshall said for comfort, for emotional support there. So yeah, let them ride. Let them ride. Once again, they're going to be very, very valuable. All right, so you are en route with the patient. Your vital signs, these are your repeat vital signs. You got a heart rate of 111. He's still sat at 98%. You're breathing for him now at 12 breaths per minute. Your end tidal still at 41. No change in his map or his blood pressure. So there's no big concerns when it comes to his vital signs. We know that he is tachycardic. He is running the fever. That's one of the things to think about. All right, so you call in your radio report to the emergency department during your reassessment. You note that your patient starts to become agitated. He's moving his head. He appears to be fighting your attempts to ventilate. Your bad compliance become poor. You reassess his vital signs. The mom asks, are you okay? Do you know what's going on? You got a heart rate now of 132. He sat at 86%. You've got difficulty bagging, poor bag compliance. 52 is his entitled. His blood pressure just jumped up to 138 systolic with the map of 95. Okay? What's going on with this patient? What's happening? I see you, Marshall. I see you. I see you, Macintosh. What's happening? I see you, Adam. What's happening with this patient? Agitation, a drop in his O2 sat, increase in his CO2. His blood pressure has jumped up. His map has jumped up. Okay, Dawn, I see you as well. Okay, all right. I love it. I love it. One of your biggest issues, one of your major complications when it comes to this device, that tracheostomy tube, is it getting plugged up with mucus? Is it getting plugged up with mucus? Now, my next question to you as a provider, we've got a few paramedics in here. We've got a few AMTs in here. Majority we have EMT basics. Are you able to suction this patient's tracheostomy? Marshall said yes. All right, Marshall, identify your level. McIntosh says yes. Okay. Marshall County said basics can. McIntosh says EMT. Okay, yes. Now, I challenge you to check this out. This is considered an invasive procedure. An invasive procedure when it comes to sucking or suctioning a tracheostomy tube. As a basic EMT, oh, there you go. There you go, McIntosh. Keep that thought. Can perform oral pharynx suctioning, which is not an invasive procedure. So you have to be very careful here. This is where that caregiver comes into, or this is where, as far as valuable, this is where they come into play here. The suctioning. Ask the care provider, McIntosh says, to suction the patient. Now, someone asked, what type of suction tubing are you using? This is a flexible, soft tubing, exactly, Marshall, or AKA whistle tip, because once you hit suctioning, they're going to start whistling. You're going to hear a little whistling sound. But this is a soft, flexible tubing that's used to suction this particular device. It's used for this invasive procedure. Now, as a provider, one of the last things that we want to do is step outside our scope of practice. Because once we step outside of our scope of practice, you document, this is where trouble come into play. This is where trouble come into play. Once again, this is why it's so important that you know your protocols. You know your protocols as a provider. Now, a troubleshooting mnemonic that can be used to help you identify any airway, whether it's or any tube, ET tube, supraglottic tube, basically any tube to help you troubleshoot is DOPE, DOPE. The D stands for displacement of the tube, the O stands for obstruction, P stands for pneumothorax, and the E stands for equipment failure. So any type of tube that this patient may have, it can be troubleshooted with this mnemonic DOPE. Once again, the D stands for displacement, O obstruction, P pneumothorax, and E equipment failure. So you successfully suction your patient or our ALS providers. You reassess the vital signs. His heart rate has dropped back to 116. His O2 sat is improved. His end tidal is back to where it was. His blood pressure is dropped to 122/58, and you've got a map of 79 after suctioning patient. You continue treatment. En route to the hospital, you call for a radio report with an ETA of 6 minutes. After arriving at the emergency department, your patient is transferred to the emergency department staff for further evaluation. Any questions? Okay. If there are no questions, once again, this is going to be the